Hello, assalamu alaikum. Good morning, students. Actually, it's evening, so good evening. So, we will begin our today's lecture from. Am I audible? Okay, so we will begin our today's lecture where we left yesterday. We did Bithanicol, carbachol, and methacholine. These are the cholinergic agonist drug, which are direct agonist. And we left our lecture to start with pilocarpine. So today we will study the fourth drug, that is cholinergic agonist and a direct agonist. I told you yesterday that what are direct agonists? They directly bind at this particular level. Okay, the direct agonist drugs directly come. Wait a second. Are you able to hear me? I guess now it's okay. So these direct agonist drugs do not have to do anything with acetylcholine esterase. They directly come and bind to this receptor. Either it is betanicol, or it is carbachol, or it is methacholine, or it is pilocarpine. So now we are studying pilocarpine. So just say, for example, this drug is pilocarpine. Okay. Now there is one very important MCQ regarding pilocarpine that you should know, that pilocarpine is an emergency drug for what? So you should know that pilocarpine is an emergency drug for glaucoma, both open angle and close angle glaucoma. So that is its therapeutic application, that it is for both open angle and close angle glaucoma. Okay, now I told you that how open angle and close how it is with play its role in case of open angle and close angle glaucoma. Okay, so let's see at which particular receptors this pilocarpine works. First of all, we have to see that at which particular receptors it works. So it mostly has this muscarinic activity. So that means it is acting on the M. Okay, and by seeing its actions on the ciliary muscles of the eye, I showed you a picture yesterday. I kind of draw it yesterday, that this is the cornea. Okay, and then this is the rest of the eyeball. Okay, this is the cornea, this is the eyeball, and then here you have this lens. Okay, here you have this lens, and then at this particular level you have this iris, and then that iris is joined to the ciliary muscles. Okay, this is the iris, and it is joined to the ciliary muscles. So these are the ciliary muscles over here and over here. So what it does is it contracts the ciliary muscles. When ciliary muscles will contract, the both of the iris, okay, the iris will come closer to each other. Okay, the iris will come closer to each other, and because of that, when it contracts, it makes some space at this particular level, more space, and when we see this more space, it allows the vitreous humor over here behind your lens, okay, flow outwards into this cavity where aqueous humor is, and then it goes and drains to this trabecular meshwork. Okay, so that is how I kind of showed you the diagram yesterday for pilocarpine, and if like I can show you it again, the diagram for open angle glaucoma, that what actually happens in this, yes, we used, wait a second, we used this particular picture yesterday. Okay, we used this picture yesterday, and I told you that, you see, in open angle glaucoma, what is happening, this is open, okay, and this is closed. So you see the angle at here, over here there is a canal present that we call Sclem's canal, okay, or the canal of Sclem's, that drain this aqueous humor and vitreous humor out. Okay, so you see here is there is a trabecular meshwork over here at this particular level. We have another very good picture, this picture. In this picture you can see all of this area, this region, all of this region, this disc, this is trabecular meshwork. So this region is cornea of the eye. Okay, it is transparent so that light can pass through it. Okay, and this is the lens, and this little circular portion left, okay, is basically what we call pupil, and it lets the eye go and like touch the rod and cone cells present at the back. In this is ciliary muscle. This muscle is ciliary muscle, and this line which I'm drawing right now is iris. Okay, it is iris. So what happens in in open angle glaucoma is this the ciliary body has to contract. Okay, now just say for example, you see a little space is left at this particular level, but when the ciliary body will contract, this iris will move like this. And now there is even more space over here and also over here, which will let the fluid stored in here that is not able to flow out will flow out and will drain through this trabecular meshwork. So this is open angle glaucoma. So this drug, pilocarpine, is contracting ciliary muscles, okay, of eye, and is helping for the treatment of open angle glaucoma. Okay, similarly the pupillary sphincters, okay, for the close angle glaucoma. Now how in close angle glaucoma it helps, okay, how does it helps in like pupillary sphincters? You see this at where is the diagram? You see at this particular level, you see how this iris is stuck at this place, and there is no space over here as well as over here. So in close angle glaucoma is more dangerous because all the humor is filled in the vitreous body, and then it kind of, you know, it kind of exerts pressure on the walls of the eye. It kind of exerts pressure on the walls of the eye and also the optic nerve present at this particular level. So it opens this trabecular meshwork, okay, the sphincters of the pupil, like, and all these muscles, okay, they kind of contract and they make this a space. It goes in back, and then it helps the humor flow through this trabecular meshwork. So this is how we open our trabecular meshwork in patients with these. So it is a very important MCQ to remember that pilocarpine is an emergency drug. It is an emergency drug, okay, to treat both open angle and close angle glaucoma. So now you understand the mechanism of action of open and close angle glaucoma also. Okay, then you see it is written that it is resistant to acetylcholine esterase enzyme, as it was written at this particular level, and it was written at this particular level. So that typically means that the drug pilocarpine is present at this receptor, and when this enzyme acetylcholine esterase will come very happily to destroy it, to hydrolyze this drug has its protective barrier present against this enzyme acetylcholine esterase, and this enzyme will not work on this drug, so that this drug can show its maximum effect being attached to this receptor. Okay, and this receptor should be muscarinic because the activity of pilocarpine is mostly on the muscarinic receptors. Okay. Okay, then you see the most important thing in this direct agonist you read the very first time and you have not read in the previous drugs we studied is that pilocarpine has a tendency to cross blood-brain barrier. It is a tertiary amine. So any drug that is a tertiary amine, okay, you will if you like kind of go and give it a read of pilocarpine from Lippincott, okay, or other drugs, you will like kind of understand that any drug that has this three amines attached to it. Amine is NH2, okay. So when you will see that this drug, if this drug has a structure of like three amines attached at this particular level, so it can easily cross the blood-brain barrier. That's its about its structure, and this is important because when a drug can cross blood-brain barrier, it can affect the central nervous system. Okay, so the drug, it can be dangerous as well. Okay, so the doses are really very important in case of pilocarpine. It has a very long duration of action. Okay, like I can say that its activity is like, you know, for every drug, there is a threshold point. To reach that particular threshold, the action that it performs in the beginning is really fast. That is why we use this drug as an emergency drug, but the effect of this drug lasts for 4 to 8 hours. Okay, the effect lasts longer. So if, for instance, you give a higher dose of pilocarpine to the patient, it can cause serious adverse effects because it can cross the blood-brain barrier. Okay, so the action lasts longer, but the threshold comes really quickly. Getting my point? So these are the actions of this drug. Along with these actions, when you kind of read its therapeutic applications, so you have this thing you have studied, the open angle and the close angle glaucoma thing. Okay, you have studied this point, and then the next point you see over here it is used in Sjogren syndrome. Okay, what is Sjogren syndrome? The S is silent. Okay, so it's called Sjogren syndrome. So in Sjogren syndrome, the patient has dry mouth and the patient has no tears. Okay, there are lack of tears and the mouth is also dry. So I told you in the previous page, if you kind of remember this previous page, I told you that this drug has the effect on the secretion of glands, and which includes the lacrimal glands and the salivary glands. So this is its action. So that means that pilocarpine will help increase the salivation, and the lacrimal gland will also work, so it will produce tears. So it can treat the patient of Sjogren syndrome as well. Okay. So this is another important therapeutic action of this drug. Okay, but when we are treating the patient with with glaucoma, we use drops. Okay, this is clinical thing that I'm telling you, that for glaucoma purposes we use drops of this drug. Okay, but when we treat the patient for Sjogren syndrome, this drug is given orally. So this is another point. For oral, for Sjogren syndrome, this drug is given orally. Okay, so if you kind of want to know more about it, so we will be studying it in this is an immunological disease, okay, so it's autoimmune. Then you see here there is another thing written, the word xerostomia. What does xerostomia means? Xerostomia means dry mouth, okay, so that's what I've said. But if they have not mentioned lack of tears, so you can kind of write that there are two things you see in the patient with Sjogren: xerostomia and lack of tears, or you can write dry eyes, okay. So even in the patients who undergo radiotherapy, the patients who have cancers, they also have xerostomia, okay, they also complain of this dry mouth. So you can use in those purposes. Also, if you have good knowledge of ophthalmology, clinically, you might have heard the word iritis, okay, iritis. That means inflammation of iris, okay. I've shown you iris in the diagram. um, this is the iris, okay. So when this iris is inflamed, it will block this pathway as well. So in the inflammation of iris, when the iris is inflamed, it basically is not like it does not get attached to the lens, but I draw it like that, but like if I'll draw it like properly, it will be like this. So what is happening now is the humor can flow from here to here, okay, and then it accumulates into this aqueous chamber, okay, and it will not flow through the trabecular meshwork because the iris gets stuck to the cornea. The iris gets stuck to the cornea. So when the iris is inflamed in iritis, the iris got stuck to the cornea, it is attached, so it's kind of blocked this aqueous humor pathway, okay. But ultimately the end result will definitely be glaucoma, but that glaucoma would be close angle glaucoma, okay. You're getting my point. So these are like the therapeutic actions of this drug, okay. So they can ask you indirectly like inflammation of iris as well apart from glaucoma, okay. And then you should know Sjogren syndrome is also treated by this drug, okay. Acha. Before moving further to the indirect and agonist, you should know that there are some other drugs that also treat glaucoma. So for when we are studying for exam purposes, it is very essential to make a differentiation chart, okay, so that when we are studying a particular disease, at that particular level, we have to kind of know that what are the other drugs we use for that purpose, so that when you will be like studying those in pharmacology, you can correlate that, okay, we also learned another drug back then that was pilocarpine. So okay, and then at that moment you will remember that I told you the other drugs. So for the treatment of glaucoma, not only we use this pilocarpine, but we use a beta blocker, okay, which is timolol. So you can kind of write, but they are not emergency drugs, okay. So for the treatment of glaucoma, we have the emergency drug as pilocarpine, but the other drugs are timolol, okay, which is a beta blocker. And then we also use another drug, which is acetazolamide, okay. So when you are working in a hospital, you will see in the emergency for glaucoma, the ophthalmologist will prescribe this, but in a setup like OPD, they will not be prescribing pilocarpine, okay. So acetazolamide also decreases the intraocular pressure, okay. It is a carbonic anhydrase inhibitor. We will study this drug in more detail, okay, when we will be studying renal pharmacology, okay. This is a renal pharmacology drug because it acts on the proximal convoluted tubule, okay. So this is renal drug, carbonic anhydrase inhibitor, okay. It inhibits that enzyme, and its name is acetazolamide, okay. So you should know these drugs too. They're also used in chronic conditions of glaucoma. Okay. Yesterday we studied one more drug for the open angle glaucoma, which was carbachol, but we do not give this drug in case of close angle. Okay. So these are the differentiating points. Glaucoma is very common, so you should know the drugs for it. Also, I told you to remember regarding methacholine that it is used in the challenge test for the diagnosis of asthma. So remember this, when we will be studying respiratory pharmacology, you will be studying many more drugs for asthma, like the corticosteroids and the short acting and the long acting ones. Okay, and many further drugs also, like leukotriene inhibitors, etc. So kind of right now just remember that it is used only for the challenge test for the diagnostic purposes. Okay, now let's move to this indirect agonist. Okay, so acha, before moving, kindly I wanna tell you, like I told you yesterday also, that for all the direct agonist, the antidote for them, if the patient gets a higher dose of it, so and goes into cholinergic crisis. I explained you cholinergic crisis yesterday in yesterday's lecture. So the antidote you will give the patient will be atropine. So for all direct agonist, the antidote is atropine. So you can like write down it over there. It's not written in this page. It is written in other page. Okay. So now we are going to study indirect agonist anticholinesterases. Okay. So what is the difference between direct and indirect? Let's go to the picture. You see this diagram. Okay, this is the enzyme acetylcholine esterase, ACHE. Okay, this enzyme hydrolyzes acetylcholine. Okay, now just for say example, this is the first drug. What is its name? Let me take physostigmine. Okay, for just for say example, this is the drug physostigmine. Okay, this is physostigmine. This drug will not bind to this receptor. This drug will not bind to this receptor. This drug will act on this enzyme, which is acetylcholine esterase, and inhibit it. It inhibits this enzyme. When the activity of this enzyme is no more, the levels of acetylcholine, ACH, okay, the levels of acetylcholine will rise in the synaptic cleft. Okay, so the acetylcholine that is already binded to this receptor will remain binded to this receptor for a longer period of time, because there is no enzyme that will hydrolyze this acetylcholine neurotransmitter. Okay, so this is how all the indirect cholinergic agonists work. They inhibit the activity of acetylcholine esterase and allow acetylcholine to remain longer in the synaptic cleft and remain longer binded to this post membrane receptor. Okay, they directly does not bind to the receptor. Okay, so this is how they work. They are like the indirect agonists are like guards. They serves as guards, extra guards you're giving to your body, and they go and hold this enzyme for some time and let the acetylcholine do its work. So they are like guards. Okay, they don't hijack acetylcholine as the direct agonists do. So now you see, that is why another name for this indirect agonist is anticholinesterases, because they're working against the acetylcholine esterase enzyme. Okay, and all of their functions, in all the actions, you see there is an increase ACH, increase ACH, increase ACH, increase ACH and increase ACH. So the functions, the main action will be the same because they lie in the same category. Okay, so let's see their names. We have this jonipazole, rivastigmine, galantamine. Now the importance of these three drugs is just one. You have to remember that this is used as the first line of Alzheimer's disease. Okay, it is used as the first line of Alzheimer's disease. What happens in Alzheimer's disease? The patient undergoes short-term memory loss. Okay, it is a problem in the hippocampus. Okay, the hippocampus deals with the memory, and the patient undergoes this short-term memory loss, and that is what is like, we'll not go in lot detail of it, but you have to kind of remember this point, that this is what Alzheimer's disease is. Okay, and this is the first line drug we use for that particular purpose. Now, in case of Agrofonium, now you can remember it by this mnemonic also, that they have the best thing about first aid is they make mnemonics. Okay, so you see Donna Riva dances at the gala, so they named this girl whose name is Donna Riva. Okay, and then there is the ceremony which is gala. So you can remember donepezil and rivastigmine and galantamine. Okay, so now it is easy to remember about this drug. So you don't need to remember the actions because it is in name of this category. Okay, the next drug we have is Agrofonium. Now, very important drug which was previously used but not now too much used, because you see this is the new version of book. If you will go and read Lippincott, or if you will go and read the older versions of first aid, you will not see that they have written historically in that. It is used to diagnose Myasthenia Gravis. It was previously a test which was called Tencelon Test. Okay, but you should know, being a doctor, there was a test which was called Tencelon Test. Okay, what happened in that test is we give this drug to the patient, and it goes and act and prevent this acetylcholine esterase to hydrolyze acetylcholine, and acetylcholine remain bind to this receptor for the longer period of time, and it helps the muscles to contract. Okay, it helps in the contraction of muscles, because in Myasthenia Gravis there is a problem of the muscle contraction. Okay, there is delayed muscle contraction, and this disease always starts from small muscles. Okay, so like eyes, or the patient will complain of twitching, or when the patient will wake up, the patient will be feeling fine, but as the day will pass, the patient's activity will get dim, and the patient's muscles will have this fatigue. So because of lack of what we can say, lack of acetylcholine binding to that receptor. So we used to give this Agrofonium because it has a very short duration of action of 10 to 20 minutes only. So in 10 to 20 minutes it does its work, and we were able to diagnose Myasthenia Gravis. But now, because they have researched and came to a conclusion of this antibody, which is anti-acetylcholine receptor antibody. Okay, this antibody comes and bind at this level like this. Okay, not like this. There are so many receptors. So just say, for example, there is this another receptor, so this antibody will like come and bind like this. Okay, so it will block two receptors at the same time. So another antibody will come and bind two receptors at the same time. So these antibodies are acetylcholine esterase anti-acetylcholine receptor antibody. Okay, acetylcholine receptor, AB antibody. Okay, so and anti-acetylcholine receptor antibodies, does it work? So now there is no need of giving Agrofonium. Okay, so that is why you have to remember this. this antibody name. Okay, so next drug is we have neostigmin. Okay, what neostigmin do? Now you see, they have not told you here at this level that either they cross the blood-brain barrier or not or something. But if they have like kind of mentioned it in here and in here, that means these are important to know, because they do ask in MCQs. Okay. So you have to remember the difference between neostigmin and physostigmin. That neostigmin has this quaternary structure, okay, quaternary amine, whereas physo is the tertiary amine, and neostigmin, because of its quaternary structure, it does not cross the CNS. And you can remember it as neo for NO, no, okay? So no is like neo, so no CNS penetration. And for it is free from F, but like you can pronounce it when PH as F also. Okay, so now physostigmine is, you can remember with PH it is free. So that means it can freely crosses the blood-brain barrier. So it has the tendency to cross the blood-brain barrier. So these points are important. Okay. Uh, Now, while moving to the detail of these drugs, one more thing I wanna, because we are studying myasthenia gravis right now. Now you see that it this level, at this level, you have seen that we didn't read anything regarding the skeletal muscles. Okay, you didn't read anything regarding the skeletal muscles. But if you remember, I told you the functions of M1, M2, M3 in a lot more detail, and I told you that this M3 also has some levels of functions on these skeletal muscles, but it is not written in this chart. So do not get confused, because this is a very high yield book, so they should not miss any point, but they kind of sometimes. That is why we have this new edition every year. Okay. Okay, now its therapeutic use is post-operative and neurogenic ileus. I told you yesterday what is neurogenic ileus, that post-operative also and neurogenic also. When your small intestine part ileum, okay, the nerves supplying to this ileum, okay, when they become distorted or damaged because of any operation, surgery, okay, or their nerves are distorted from their root values, okay, in any case, okay, in any cause, if the cause is surgery or if the cause is some neurological trauma to that nerve, we see that the food, the bolus present inside this ileum will not be moved forward, will not be moved forward. So the patient will be retaining food inside the small intestine, okay, and with the passage of time, the patient will feel pain, bloating, flatulence, etc. So in those conditions, when the patient will come to the emergency, and you will be like, the patient will complain that I am having constipation and I'm not able to pass a stool for like a week or two. Okay, and then being the doctor at the emergency, you have to check that either that constipation is relative or it is absolute. Okay, we have these two terminologies when we work in a surgical emergency unit. Okay, so in this relative constipation, the patient does not pass a stool, but the patient can pass the flatus. Okay, but in the absolute constipation, it is absolute, like complete, no flatus, no stool. Okay, but in relative, there is flatus, but there is no stool. But in these conditions like neurogenic ileus or post-operative ileus, when the nerves are destroyed, okay, and there is no contraction, it, the patient will come with absolute constipation, which is very painful. So at that level, you can consider this neostigmine drug and also bethanicol. Also bethanicol, because we studied in therapeutic actions that bethanicol has, it is not written in your first aid, but it is present in your textbooks of pharmacology. Okay, so you should know that we can give a direct agonist and we can give an indirect agonist in these conditions. Okay, then the another thing is urinary retention. The patient is not able to pass the urine, and we know that acetylcholine helps in contraction of the detrusor muscle. Okay, and the patient will be able to pass urine. So we can give this drug in retention case also. Okay, now that retention can also be due to some surgery, or that retention can also be because of, you know, in postpartum delivery, sometimes the nerves gets injured. Okay, so it can be because of that, but make sure that urinary retention should not be because of stones. Okay, the stones, the renal stones that stuck into the renal pelvis or calyx, and then it moves to the ureter or the bladder or the urethra. The stones must not be the cause of urinary retention, because you can't let the person pass urine via drug. You have to remove that stone either by open surgery or either by lithotripsy. Okay, so you have to make sure that the cause of urinary retention should not be a stone before prescribing a direct or indirect agonist. Okay, again, in urinary retention, you can give bethanicol or neostigmine, both. Okay, then again, myasthenia gravis. Okay, but over here now, we are giving this to treat myasthenia gravis, to help the patient relieve his symptoms. Okay, we are not giving this drug to diagnose. Okay, this was a drug previously given but not used now. So now for the diagnosis, you are using this antibody. Okay, but for the treatment purposes, to relieve that complaint the patient is having of slow muscle twitching and, you know, all that things, you can give the neostigmine to activate that process, and the patient might get, you know, energetic and his muscles work like a normal person. Okay, so this, you can give this neostigmine to the myasthenia gravis patient. If you want to learn about myasthenia gravis in detail, that will become in like neuropharmacology. Okay, and I will teach you in detail how it works. Then reversal of a neuromuscular junction blockade post-operative. Okay, so what's it doing, that after a surgery, after an operation, the neuromuscular junction, just for say for example, this is NMJ now. Okay, and this is the NMJ receptor. Just for suppose this is NM. Okay, NMJ receptor, neuromuscular junction. So what is this drug is doing? It is causing reverse. Okay, like when because of a surgery, this your neuromuscular junction is damaged, or its receptors are not working properly. Okay, and then this acetylcholine esterase is also coming very fast to hydrolyze this drug. Your neostigmine will keep hold of this little buddy here. Okay, and let the acetylcholine do its work on these receptors. So it kind of reverse that traumatic situation that was occurring before. Okay, that the receptors are doing their work slow because of a post-operative damage, and also the acetylcholine is playing its role on double hand to destroy its function really quick. So now we are helping this post-operative this process by holding on to this acetylcholine esterase here. Okay, so it's very important to understand every word of first aid book, because they don't put unnecessary stuff in here. And we are left with like 4 minutes 44 seconds to end this meeting. And if this lecture ends after this, you have to join it back again from the group, okay, from the group of WhatsApp, and I'll wait for you people. Then we have this physostigmine, okay. Now, very important thing to tell you, Acha, before hopping on to physostigmine, I want to tell you a difference between there are two diseases. One is myasthenia gravis, and the another one is Lambert-Eaton syndrome. Okay, we have these two diseases, myasthenia gravis and Lambert-Eaton syndrome. So what is the difference between these two? Okay, let me show you in the picture. Just for say example, this is NMJ, okay. Just for example, this little buddy is NMJ here, and this is a neuromuscular junction receptor, okay. The auto antibodies will bind to these receptors, okay, in the I'm telling you the diagnosis, okay, in the in myasthenia gravis, okay. But when we talk about Eaton-Lambert or Lambert-Eaton syndrome, there are, they come to this. Wait a second, people. Where is that picture? Okay, so now this is a very important concept. If you'll understand it now, it will help you further when you'll read that also. Eaton-Lambert syndrome. In Eaton-Lambert syndrome, you see this calcium ion channel over here, okay. The antibody that will be produced in this disorder will be against this. It will block this. When the calcium will not come inside, there will be no depolarization. When there will be no depolarization, this synaptic vesicle will not come and fuse with the membrane. The acetylcholine will not be released. So in Lambert-Eaton syndrome, the patient do not have problem at this level. The patient has problem in the pre-membrane level, okay? But in the myasthenia gravis, the problem is at this particular level, at the NMJ, neuromuscular junction. Okay, so you have to remember the difference, but the end result is same. The end result is same, okay? So that is why in the MJ, in the myasthenia gravis patient, you see when the patient wake up from bed, the patient is fine, but with the passage of time, the patient's activity decline. Why? Because the acetylcholine has been released, but as he like function more and more, so then there is not the sufficient in this left in this cleft, okay, because these are destroyed. Okay, you getting my point? But when we talk about Lambert-Eaton, when the patient wake up at that particular level, his activity is already declined. So because of no acetylcholine release, okay. So these are the basic differences in between these two diseases. So you should know this. Now next, let's move to the next drug. I think I'll begin this next drug after this 1 minute. We are left with 1 minute, so I may stop and I may join it again, okay, so that you may not miss it.